silent support still pretty off.
Thank you, Madam.
Yes, Mr. Vansberg.
Dr. Perumal, during the interval, did you locate that authority which I requested you to source or tell us about with reference to specifically the reduction in downward force involved in various levels of or types of partial hangings?
Yes, I did, Madam.
Right. Now, I want to ask you, what is the source? Who is the author of the authority?
The authors are Michael Shukram and David Ramsey. It's the front page of that particular authority is page 84 of the bundle that was handed this morning.
Yes.
Triple L. That's the front page. But that bundle has documents from the book starting at page 78. But the information, my lady, that is requested is in the same book, but page 70, which is not in the bundle.
Right. But in any event, let me just deal with it. These authors, Sutram and the other, to what extent are they regarded as authorities in the field of forensic pathology or forensic medicine?
It's certainly one of the books that is referenced and part of the library at the university, but it's not at the level of Knight, Bernard Knight, for example. That's our gold standard.
Right. Now, just take us through the tests that have been done in this regard with a view to showing how the mass is reduced depending on, well, let me say how the downward force is reduced depending on the type of partial hanging.
Yes, my lady. The two learned authors are quoting a study by Khochlov, K-H-O-K-H-L-O-V. Standing, toes touching the floor, reduces from 100% to about 98%.
Right.
Standing with the feet flat on the ground can be reduced to as low as 65%.
Right. Carry on.
Then kneeling but the buttock down, 74%. Kneeling with the buttocks up, 64%.
Now, if we just look at the scenario of a person who hangs herself with her feet on the ground, you said up to 65% reduction in mass. So if somebody is weighing 52 kilograms, what is 35% less? What would that amount to in terms of downward force?
It's 33.8.
Right, 33.8 kilograms. Now, I'm coming back to your authorities in a moment, but at this stage we've got to paragraph 5 of your report, and I'm going to skip 5.2.1 at this point, because I'm going to deal with it after your conclusions.
Sorry, Mr. Van Spade, the stenographers just indicated there's some interference possibly from cell phones. If everybody could just make sure that the cell phones are turned off.
Thank you. Mine is definitely off, my lady. I turn it off at home, in fact. Dr. Perumal, let's get to your paragraph 6 now. And I would like us to press on a little bit there.
Yes.
Summary of the second post-mortem examination conducted by myself revealed various findings similar to those made by Dr. Khan, but the material differences were as follows. And then 6.1, the ligature was almost circumferential around the neck, and the point of suspension was most likely below the right ear. We have dealt with that.
Dealt with that, yes.
I did not find any ante-mortem fracture of the left corner of the thyroid cartilage. It is my view that this is a post-mortem artifact and appears incised without hemorrhage at site. Right? We've dealt with that.
Yes, and I went further yesterday to say I don't have an issue of accepting that as an antemortem.
Either way.
Yes.
6.3. In light of the prior specialized neck dissection by Dr. Khan, I could not find definitive antemortem bruises. You have dealt with that,
yes.
Paragraph 7. Information obtained from Mr. Rohde during his testimony. Mr. Rohde's wife was injured on her right thigh at the gym some 7 days prior to her death. I believe that is common cause.
That's
now.
right, yes.
Mrs. Rohde walked around barefoot on a corrugated surface. I'm not sure what you mean by corrugated, but it was a paved surface.
Yeah.
She fell 1 or more times. Prior to commencing CPR, Mr. Rohde observed a trickle of saliva flowing from the left corner of the deceased's mouth. 7.5, a short while later, Mr. Thompson arrived and assisted with CPR. Later, paramedics arrived and commenced with CPR. You put in brackets with a question mark. You're not sure about that?
Sure, no.
Okay. Photographs revealed a ligature mark on the neck, which on the left side laterally and anteriorly manifests some abrasive bruises. The ligature imprint is deep and transverse on the left lateral neck. Small abrasions behind the right ear. Hemorrhages into the soft tissue of the neck, especially related to the inferior aspects of the mandible. That's the lower jaw. Minimum hemorrhages related to ribs 3 and 4 left side anteriorly. Now we have dealt with all of this so far. We're going to get back to 1 or 2 points here. But is there anything here in particular that you want to draw our attention to insofar as your findings were concerned?
Yes. My lady, I know that during the cross-examination of the accused, there was about the most probable site of the point of suspension of the ligature. And I don't know what to make of it, but there are 2 focal abrasions on the right side of the neck. I can get a photo to show that. I think it's at the autopsy photos that show it better. There are 2 focal abrasions. I don't know the cause of that, but it may just be linked.
Those are the ones behind the ear?
Yes.
Yes, you showed us that.
Okay, that may be linked to a ligature, the actual knot in that region, yes.
That's a possibility.
That's a possibility, yes.
Let's move on to paragraph 9. Comment. As an expert witness, I am fully cognizant of the fact that I owe no favor to the party that calls me, but that my duty is to assist the court as an independent and objective witness.
Yes, that's what I'm hoping to do, yes.
And just for the record, you are standing there in the witness box in your capacity as a specialist forensic pathologist of 29 years registration and practice, on top of your period of speciality, and before that, the forensic work done when you had your diploma.
Yes.
And you are speaking in your capacity, in your dual capacity as the head of forensic pathology services for the province of Mpumalanga, and as a practitioner with a limited private practice in forensic pathology.
That's correct, my lady.
I'm not sure if you are still engaged in training students in Natal. Can you clarify that?
Yes, I do, but not at the undergraduate level. At the postgraduate level only.
Right. Let's go to 9.2. I am fully aware that it is primarily the function of the court to make a finding as to the cause of death and the manner of death. I am also fully aware that there are some difficulties and challenges associated with performing a second post-mortem examination, and that post-mortem artifacts need to be considered at all times.
Yes.
9.4. As asbestos forensic pathologist, I was surprised at the comment made by Dr. Khan at the scene regarding the husband's passport being removed. It seems that a conclusion was reached prior to the post-mortem examination being conducted. Now, you have dealt with those 3 points at reasonable length. Is there anything special that you need to add at this
No.
stage? Okay. 9.5. It is often not possible to use the findings made at the post-mortem examinations to hold a probability view on whether they are more in keeping with manual strangulation or suicidal hanging. 9.6. Dr. Khan commented that the features of the ligature imprint that he observed were consistent with the ligature being applied to the neck after death. He stated that the imprint was not parchment-like or leathery. However, the parchment-like or leathery appearance of a ligature is usually associated with a ligament that is not smooth, i.e. a ligature like a rub. This creates a friction-type abrasion and release of a serous-type fluid which, when dry, results in the leather-like feel and parchment-like appearance. The ligature in question in this matter was an electrical cord which has a smooth surface and is likely to leave a rounded impression with very little abrasion in the imprint. Now, subsequent to that, you examined once again the scene photographs, and in particular the photographs of the ligature mark taken at the scene of the alleged crime by the police.
Yes.
And we have had your evidence in that
Yes.
regard. Is there anything that you want to add to this?
No, nothing further, lady.
9.7. There was prolonged CPR conducted by Mr. Rohde and Mr. Thompson, and CPR was possibly also conducted by the paramedics. The linear and curvilinear abrasions are almost horizontally orientated and are closely related to the undersurface of the mandible, the lower jaw.
Yes.
These are associated with contusions of the underlying soft structures. The aforementioned skin and underlying soft tissue hemorrhages are very typical of resuscitation artifacts, whereas linear and curvilinear abrasions associated with throttling are usually vertical and on the anterior and lower part of the neck. Now I see wherever we go here, you're referring to authorities, and we're going to go and deal with that as a bundle.
Yes.
But is there anything you want to add to that? You have expanded on that in your evidence.
That's correct, my lady.
Okay. The bruises of the sternocleidomastoid muscles, the thyroid gland, and possibly related to the left cornea of the thyroid cartilage, as well as the alleged fracture of the left cornea, the hemorrhage on the anterior part of the cervical spine, are in any event all frequently to be observed in hanging. You've told us that.
Yes.
Soft tissue hemorrhages in the neck are a common finding in hanging, and you've given the references there. And injury to skeletal structures of the neck are also common and may be as high as 67% in persons over 50 years of age. The soft tissue injury and skeletal injuries being the result of convulsions associated with anoxia in hanging. Right. Is there anything you want to add to that?
Nothing further, my lady.
Thank you. 9.9 deals with the fractures that you observed of ribs 3, 4, and 5 on the right side anteriorly in the front, and the fracture of ribs 2 to 5 on the left side anteriorly, and the fracture that you observed of the middle third of the sternum. The 50 milliliters blood-stained fluid in the right chest cavity and bruises of the left lung could all well be a consequence of resuscitation or as a result of blunt force injury.
Yes,
Anything you want to add?
Nothing further, my lady.
Right. The pallor of the tip of the nose, that is, of course, if it was present, could be a result of resuscitation. There may only be support for smothering if there were subcutaneous bruises observed upon facial flap dissection or imprint bruises or lacerations on the mucosal surfaces of the lips or cheeks from outside pressure onto the underlying teeth. I observed none upon performing the facial flap dissection. 11th point. The scattered abrasions on the face, shoulder and limbs are all the result of blood force trauma and may result from Mrs. Rohde impacting on something blunt, for example falling, or if a blunt force were applied to her.
Yes, correct, yes.
Mrs. Rohde sustained a blunt force injury to the nose. This is the most likely source of the fresh blood observed in the stomach and altered blood observed in the small bowel. These observations indicate 2 separate episodes of nasal bleeds and that Mrs. Rohde had swallowed the blood. You've dealt with that already in your testimony. Do you want to say anything more?
Nothing further, my lady.
Thank you. The bruises on the right arm, and left forearm are typical of restraint injuries but could also result from blood force trauma.
That's correct.
The blood around the mouth and nostrils may be related to the congested lungs, usually associated with an asphyxial death. Do you want to say anything about that?
No, nothing further.
My recollection of the evidence in this regard is the following, that Mr. Rohde, when he placed his wife on the ground on her back with a view to trying CPR, the first thing he observed was a trickle of saliva coming from the left-hand corner of her mouth, which he wiped away, and that at some stage or another during the CPR efforts, blood was observed coming from the mouth and the nose of the deceased, and that it was wiped away by means of a tissue by Mr. Thompson. And I think Mr. Thompson confirmed that. Do you recall that testimony?
I do recall that.
Is that what you're referring to here when you mention the blood around the mouth and nostrils?
Yes, it's my lady, it's more blood-stained fluid rather than frank blood.
Okay. 9.15. The absence of post-mortem lividity in the lower limbs and its presence at the rear of the body is an indication that Mrs. Rohde either died in this position or that she was removed from a suspended position prior to the post-mortem lividity fixing.
Yes,
Okay.
we covered that.
We've covered that.
Yes.
Now, a point that we haven't covered yet. The blood alcohol level at the time of Mrs. Rohde's death was 0.05 grams per 100 milliliter. On the basis that Mrs. Rohde had her last alcoholic beverage between 2 a.m. and 2:30, that's in the early hours of the morning on Sunday the 24th of July 2016, she would have been on the descending limb of the blood alcohol curve at the time of death.
Yes.
She would probably have eliminated between 0.01 grams and 0.02 grams of alcohol per 100 ml per hour.
Yes.
Over the 6-hour period, she would have eliminated between 0.06 and 0.12 grams per 100 milliliters. The blood alcohol level at 2 o'clock.
Sorry, there's a bit of a typo, excessive typo there.
I think there should be a comma there.
Yeah.
But in any event, the blood alcohol level at 2 a.m. could well have been anywhere from, and this is the important point, 0.11 to 0.17 grams per 100 ml. An average of that being 0.15 grams.
1.4, not 1.4.
Sorry, excuse me, 0.14.
Yes.
Okay. Now, do you want to deal with that because you haven't dealt with that before?
Yes. That, my lady, will indicate, I think no matter what your degree of tolerance is, that level of alcohol, and I had to work with all the averages at 0.14, someone would be influenced by that level of alcohol, and in the language we're using, she would be intoxicated. It's not easy for me, and I'm reluctant to look at mild, moderate, and severe, and very severely or strongly under influence. Suffice to say that 0.14 will affect the central nervous system of vast majority of individuals. irrespective of the degree of tolerance.
Anything else you want to add on the blood alcohol level of this of the deceased?
Nothing further, unless I'm specifically asked to comment, I will.
Right. Now, we know what criticisms have been leveled against you by Dr. Khan. Numerous criticisms, and I'm not going to tabulate them again now. But I asked you to perform an exercise, and that is to list all the pathologies, injuries, or similar manifestations that Dr. Khan missed and that you picked up. And also to list any investigations or special investigations that you performed that Dr. Khan, under the supposed supervision of Dr. Abrams, did not do. Can you let us have that? Do you have that available?
Yeah, I had it here morning. I don't know if the gremlins have visited here again, because the other documents seem to have disappeared earlier.
Just take your time, I'm sure they must be there. Nobody has touched your documentation.
Okay, they're not sure, they may just be in that bundle over there.
My lady, may the witness just go and look at his bundle here. Dr. Perumal, you have the leave of the court.
As Dr. Perumal found it.
No.
No.
Would you like to adjourn for 5 minutes?
That's a court, please.
Sorry, my lady.
Thank you.
totally open. Thank you. Thanks for the indulgence.
Gremlins returned your document. Thank you.
Thank you, Melody, for the...
Yes.
Now, I asked you to list those things. Can you take us through it, please? Can you give us a list? Just point forward.
Yes. The first one, my lady, it's my opinion that he didn't observe the ligature mark at the rear of the neck. Now,
Right.
I know counsel asked me to just give the points, but
Well,
I want
then
to just
let's
explain
stick-
a little bit.
No, let's just stick to the points.
Okay. My lady, there's a scar on the right knee, a U-shaped scar. A scar under the right breast. Bruises on the left and right arms. Bruise on the left forearm. Fracture of the ribs on the left side, a fracture of the sternum.
Just pause there, please. For the record, how many fractures on the left-hand side were there?
Just want to make sure that that's the correct number.
2 to 5.
I think it's 2 to 5. Yes. 4 ribs.
Thank you. That you picked up and that weren't reported by Dr. Khan.
Yes.
And can you just describe to us where the fracture of the sternum was located?
Middle third. The middle of the sternum.
Middle third of the sternum.
Yeah.
The sternum being the breastbone.
That's right.
Okay. Now we know Dr. Khan picked up some of the fractures on the right side,
Yes.
but not all of them.
That's correct, yes.
Okay.
Then there was, I said he didn't pick up the fractures, Malay, because he didn't do those incisions through the intercostal muscles.
Thank you. We've dealt with that.
Yes.
You're talking about the so-called spare ribbing.
Then the facial flap dissection. Was not conducted to show any pathology in the subcutaneous tissue.
With particular reference to the possibility of smothering.
That's correct, my lady. Then the facial, hemorrhage into the tongue. The tongue was not incised to reveal that. May I proceed, my lady?
Mhm.
Yeah, sorry. And then, not that it's a criticism, but he didn't do any subsequent radiological investigation. And in fairness, his findings wouldn't have required it in terms of his findings in terms of the PM, post-mortem examination that he compiled. And the organs were not histologically evaluated. That's the last point.
I have a question in that regard. We know that you did evaluate the organs, or certain of them histologically, or all the main organs at any rate, and in particular you did the lungs. Is it possible to comment on the extent of injury to a lung in the absence of histology?
It is possible to comment, but it won't be scientifically accurate. Especially if you're considering aspiration of blood or gastric content.
given us that list. Now I want to ask you to comment in your various capacities: private practicing, senior government employee, lecturer, especially in the postgraduate context. In terms of the management of a live patient, the treatment and management of a live patient, a normal patient like me or you or somewhere around here, by a doctor, and errors and remissness in terms of such treatment and management. Can you just give us a correlation in the clinical context with, in this particular case, the forensic pathology work that was done by Dr. Khan under the supervision of Dr. Abrams?
My lady, it's a general statement, but if I can just narrow it down to one specific issue in this case. The practice of medicine and the study of medicine is a science. In everyday life, we deal with formulas, and in this particular context, what was required, and I don't know what Dr. Abraham's input was, I can only comment on Dr. Khan for now. What was required for him to elicit some numbers, that is temperature reading, apply it to a formula which is predetermined and well known, and come to a conclusion using the formula. Every day in medicine, doctors are using formulas to determine, for example, the dosages of medicine, drugs that are administered. This was a clinical setup. I think the error made in terms of the calculations on a deceased person about the time of death could have had far-reaching outcome in a living person. With an adverse outcome that could be deemed negligent. Just one comment in that regard.
If I look at your report, page 9, and in particular paragraph 9.17, you say the following: the presence of saliva on the left angle of the mouth of the deceased is a strong indication that the ligature was applied ante-mortem. In other words, the saliva is a strong indication that the ligature was applied whilst the deceased was alive.
Alive, yes.
Right. Now I want to refer you to some authorities in this regard. If I may hand these up to the learned court. There are several. I'll start with these two. Two so far. I'm actually going to hand them all up at the same time. There are another two. So just just want to get them in the right order. And the other one. Thank you. Now, if we could start with the first one, and that is the Journal of Forensic and Legal Medicine. Do you have that there?
I do.
Right. Can we possibly just mark that with the court's leave? M1. Then the next article, Leicester's Medical Jurisprudence and Toxicology, if you could mark that M2, please.
Correct.
Sorry. Then if we could mark the Forensic ABC of Schwar, Olivier and Loubser as M3, please. We got that. And then the last one, if we could mark it, this is De Meyer and De Meyer, Forensic Pathology, if we could mark that M4, please, Doctor.
I do have it, and I've done it accordingly. Thank you.
Now, I don't want to wade through these articles bit by bit and piece for piece. I want you to tell us what these articles say and why, in your opinion, the presence of saliva in the left angle of the mouth of the deceased is such a strong indication that there was an ante-mortem hanging.
Malady, in M1, one looks at the introduction, 4 and 5 lines from the bottom.
In which column?
M1.
In which column?
On the left side,
Right.
introduction.
Yes, take
It
us
says
there.
the mark of saliva dribble is a classic feature of antemortem hanging, but it may not always be present in all cases.
So what is that saying when it says may not always be present in all cases?
My lady, it will depend, when I explained earlier on the various mechanisms of death. One mechanism that I indicated, and I didn't use the term acute neurogenic cardiac arrest or tachycardia. In other words, it's a autonomic imbalance. I did indicate one of them is a parasympathetic overstimulation, which will slow the heart down.
And you also said that a sympathetic one would speed up, maybe
Accelerate.
lead to a ventricular fibrillation.
That's correct. Now, the parasympathetic stimulation or overstimulation is thought to be the cause of the saliva release. Now, in the same M1, on page 3 of that, but page
Now,
80.
I just want to go back to
Oh.
the first page, please. What does it mean, but it may not always be present in all cases?
My lady, depending on the mechanism of death. If
Yes.
the mechanism of death is not the parasympathetic overstimulation, you may not get the saliva.
So the presence of saliva is a classic feature of antemortem hanging, but it's not necessarily, if it's not present, it doesn't exclude hanging. Is that what it is?
That's correct. Does not exclude antemortem hanging.
Right. Is there anything compelling in the rest of the article that you want to take us to?
The next line, I think, maybe is what applies. A reason for this is due to the wiping by relatives. That's, I think that's what happened here. It was wiped away. And then on page 82 of that exhibit, on the right column, second paragraph, one of the important aspects of hanging deaths is to ascertain the nature of the hanging, being ante-mortem or post-mortem. Features like the saliva dribble mark are suggestive of ante-mortem hanging.
Thank you. That just repeats what we've already read.
Yes.
Okay, let's move on to Gleister's medical jurisprudence and toxicology. Is there anything here which you want to draw our attention to?
My lady, on the page 2, 172 of the actual text, the last paragraph under the heading External Post-Mortem Appearances, and 5 lines down, saliva may be seen trickling from the corner of the mouth as a result of increased salivation prior to the death, and that at the time the author said it could be due to stimulation of the salivary glands produced by the ligature.
Thank you. Let's move on to the forensic ABC in medical practice. That's exhibit M3.
Yes. On the text itself, my lady, page 183, on the left column, there's some blocks of bullet points. The last bullet point is that there's emission of semen and of saliva may be due to the stimulation of the autonomic nervous system. If this is the case, then it can be taken that the emission of the semen or saliva occurred ante-mortem.
Right. Let's move to MMM4. Before we do that, let's just pause on the authors, Vincent J. DeMeyer and Dominic DeMeyer. Who are they in a nutshell, and to what extent are they regarded as authoritative?
Yes, this textbook would rank at least amongst the top 6 of our forensic fraternals recognized textbooks, father and son. Just out of interest, Vincent J. DeMeyer, many people know the book called Gunshot Wounds. That's the author of the world-renowned, respected source on ballistics.
Authority on ballistics.
Absolutely.
Right.
Now, in this particular reference, M4, my lady, page 254 of the text. A dried rivulet of saliva often runs from...
Sorry, where are you reading from?
The bottom of the first paragraph.
The last 2 lines of the first paragraph.
Yes. A dried rivulet of saliva often runs from the corner of the mouth and down the chest. That will be in a vertical position.
Yes.
Yes.
Thank you. Now, I want to move on to the 2 last things today, or one of the 3 last things. The first one is just, could we go to paragraph 9.18, your conclusions?
Yes.
Now, I want you just to bear in mind the following. The post-mortem report of Dr. Khan reflected the cause of death as in paragraph 5.2.11 or 11. Cause of death consistent with asphyxia following manual strangulation and external airway obstruction. The features of the ligature imprint abrasion mark are consistent with post-mortem application to the neck. Now, we already know your comments on the features of the ligature mark. I want you to comment on what he said here, consistent with asphyxia following manual strangulation, and then the following, external airway obstruction. Can you comment on that? The external airway obstruction.
My lady, I'm going to assume that that would mean the blockage of the nose and the mouth, obstructing it so that no air enters into the lungs and therefore creating an hypoxic or anoxic situation.
Right. Now, let's go to the last paragraph then. Your paragraph 9.18, which sums up your professional view. Having regard to the entire spectrum of injuries suffered by Mrs. Rohde, it can be stated that 1. Mrs. Rohde suffered some ante-mortem injuries which were the result of blood blunt force trauma. Correct?
Yes.
I don't think anybody disputes that. Do you need to add anything to that?
No, my lady.
Second point, the fracture of the ribs and the contusions of the lungs and the soft tissue injury to the neck were probably associated with resuscitation.
Yes, and I covered that.
3. The most likely source of the blood in the stomach and small bowel is an injury to the nose. You've dealt with that.
Yes, yes.
4. As stated in my autopsy report, my findings are consistent with ligature strangulation, i.e. hanging. However, on a post-mortem examination alone, it is simply not possible in a case like this to be adamant about the cause of death. What
Yes.
are you saying there?
My lady, at the time of doing the autopsy, I can make a conclusion on what the death is consistent with. That when I use, or generally when anyone uses the word consistent with, means these features can be linked to the pathology in question, not to the exclusion of other pathology if that is presented. Because at the time of the autopsy, my lady, we don't have the whole picture. We only got what injuries are presenting at the time of the autopsy. And so I would not limit myself as being categoric or emphatic or adamant in terms of the cause of death, because I will leave myself open to having other information given to me and say, please consider this. So I'm saying to the court that I can say that it's consistent with the hanging, but I'm not prepared to be categoric or adamant about my conclusion.
To make the final decision.
On comments, I said, it is not my role, it's the role of the court, which is going to have access to far more information than I can have.
And your comments about not being adamant, I take it, would apply equally to any person doing an autopsy in this case?
Should not be adamant.
Right. Let me now ask you a further question for the authorities that was handed up as... You have it with you.
I do?
It hasn't disappeared in amongst you.
No, in fact, now it's multiplied. I've got 2 sets.
Right, let's go to these and let me just start on... No, you supplied these authorities as a support for your own personal views.
Yes.
Can you take us through these authorities briefly now?
Yes.
And just draw our attention to those aspects that you feel are important to highlight.
My lady, in paragraph 9.6,
Of your report?
of my report, page 6, paragraph 9.6.
Let's just specify the exhibits. JJJ.
JJ, triple J.
Right. Okay. And
At
now,
the end of that paragraph,
yes.
reference is number 1, 9.6 of triple J. The reference is 1. That's the first reference, which is Venezzi's, Peter Venezzi's Pathology of the Neck. My lady, I'm only going to make reference to page 4 and 5. And reads at the bottom of...
That is pages 4 and 5 as the bundle has been numbered.
Yes.
Right.
And at the bottom right, last line, a typical roughen... Page 4.
Right.
It starts there, typical roughen mark of a rope used for suicidal hanging, which becomes dried and brown after that is due to the friction and does not necessarily indicate a vital change. Then we go to a few lines lower. The application of smoother, though hard ligature, such as a plastic electrical flex, leaves a characteristic rounded, grooved impression, sometimes with a dried brown appearance, but frequently with little discernible abrasion to the skin. It's from page 4 going on to page 5 on the left column,
Right.
which we have here.
Right.
Little bit.
You've testified about
Yes.
that. Let's move on, please.
Then we go to the next one, my lady, which is paragraph 9.7.
Yes.
And there's 3 references in 9.7. Number 2, reference 2 is attached to page 10 of mine, which is Harman Raj's.
Page 10 of your bundle, right?
Yes, gives the actual reference. And that, my lady, it's page 12 of the bundle of triple L. In the introduction, second line, the external injuries may be similar to those, and this is talking about injuries to the face and neck, my lady. And the authors here say the external injuries in the face and neck may be similar to those occurring during throttling. A similarity which may lead to misinterpretation.
And what is that saying?
That is saying the evaluation of these injuries must be carefully done, because it could lead to misinterpretation. That's why I said to the court that these could be as a result of the resuscitation, or it could be as a result of manual strangulation.
Right. Carry on.
And then on page 13 of that bundle of reference,
Page what?
13,
Yes.
of triple L, under results, third line, in 16 cases bruises and abrasions were present in the face and neck. Amongst these, hemorrhages were also found in the subcutaneous tissue, the muscles, and the fascia, that's the soft tissue plane, in 7 cases.
Are we talking about hangings now?
And resuscitation.
Oh, sorry.
Yes, resuscitation injuries.
Right.
The last line of page 13, my lady, the mandibular margins were exposed to injury during manual compression with the jaw thrust, when I was lifting it up. So, and then we go to page 14, first paragraph, third line, numerous nail impression marks beneath and parallel to the mandibular margin, which is what we see here. So that's why I said to the court to consider that these abrasions closely linked to the jawline could be as a result of resuscitation. And I'll leave that reference. And go to my reference number 3.
Well, what page is it?
And that starts at page 20.
Right.
My lady, page 20, on the right-hand column, second paragraph, it says, at necropsy, CPR-related injuries are commonly encountered, unrelated to the primary cause of death, and may mislead a forensic investigation.
Right.
And then page 22 of the bundle, triple L, on the right-hand column, discussions, third paragraph. And I'll read, ecchymosis and erosion to the scalp, face and neck are currently observed at external examination of patients who have undergone resuscitation. Now, what that means, at the back of the neck, when there's resuscitation, you can get ecchymoses. The deceased in this case had a bruise at the back of the head. Even when the wounds are mild and apparent, ordinary, they are important for a forensic pathologist who must distinguish them from those caused as an act of violence. For example, the marks left by fingers and nails on the face and the neck during resuscitation. Attempts are located at the base of the mandible, around the mouth, and between the larynx and the maxilla. The maxilla is the upper jaw. And are parallel to each other, while the lesions produced during strangulations are irregularly distributed in multiple directions, covering a large area on the neck that I explained earlier.
Right.
Page 24, under conclusions. Just one paragraph there, my lady. Injuries produced during CPR may be responsible for important artifacts impeding the understanding of traumatic lesions observed during necropsy and related to the primary death cause. A thorough knowledge of possible aspects is mandatory to the differential diagnosis with other traumatic causes.
Thank you.
Saying please entertain two scenarios.
I just want to pause there for a moment, just to record once again, or through you rather, some different definitions. What is the difference between manual strangulation and manual throttling?
Well, manual strangulation and throttling is the same entity where a hand is used to inflict pressure on the neck.
And ligature strangulation can involve hanging or a manual application of a ligature.
Yes.
Right. Let's move on to your next authority.
The next authority is my reference number 4. And I look at page 27. And on the right column, resuscitative injury, bruising, abrasions of the face and neck. Bruising and abrasions of the face and neck can occur during CPR. Even when these injuries are slight and seemingly unimportant, they can be significant for the forensic pathologist who has to distinguish iatrogenic injuries from those caused by violence. And in the bottom of the paragraph, it repeats what was said previously. In contrast, nail marks after resuscitation were localized in a more regular fashion on the mandibular base.
Right. Anything else from that particular article?
No, it's basically agreeing with the previous articles. And then 9.8. My references there are 5, 6, 7, and 8. And my lady, if we go to reference 5,
On
page 33, we can deal with the abstract. The second paragraph of the abstract, third line, injury to the sternocleidomastoid. Injury to the sternocleidomastoid muscle was 54%. It's the commonest injury in hanging, found by, let me just say this first, my lady, this source, Sharma, B.R. Sharma and his team, world authorities on hanging and the pathology of hanging. They're based in India, and worldwide, that's the highest incidence of suicide by hanging in India. And Sharma and his team are the world-recognized experts in that field. And the journal itself is also a recognized journal, Forensic and Legal Medicine. And the abstract here is saying what injuries are found in constriction neck in hanging. And these authors are saying injuries to the sternocleidomastoid is the commonest injury. And that's why I said yesterday when reference was made to the thyroid conua, the thyroid conua is the commonest skeletal injury, but the sternocleidomastoid is the commonest soft tissue injury.
Right.
The hyoid bone was fractured in 21% of their cases. The thyroid cartilage was fractured in 17% of cases. Complete hanging was noted in 68% of the cases, and a fixed knot was found to be used in 71% of cases. A single loop around the neck was observed in 80% of the cases, and it was above the level of the thyroid in 58% of the cases. Most cases of fractures of the laryngo-hyoid complex were in the age group 41 to 60. So that's the age group of Mrs. Rohde.
Right. Let's move on quickly, please, to your other authorities.
I think what the subsequent pages just reinforce that finding.
Let's move on to the next
that was
article, please.
stated. Next reference is number 6, and I make reference to page 41
Of the bundle?
42. So page 41 and 42.
Yes.
And the abstract will read, for death due to hanging is common among suicide, and then right at the bottom of that abstract is saying you've got to consider multiplicity of factors when you're making the conclusion. And then from 41 over into 42, on the bottom right, last paragraph, it says 97.62% of cases showed pale white glistening tissue underneath the ligature mark, and only 2.38% of cases showed mild contusion of the neck structures. And it goes on to the following page, page 42, detailing the injury to the skeletal structures. The next reference is reference as 6. And we stick with the abstract. They looked at 150 cases. It's the middle of that abstract, my lady. We established that there was at least one injury to the structures, hematoma or fracture, for example. Most frequent injury, again, was to the sternocleidomastoid muscle. Fracture of the throat skeleton was detected in up to 68%. Proportion of fractures increases with age. There was no clear correlation between the frequency of neck injury and the type of hanging. So whether it was a typical hanging or partial hanging. And
Right.
the article then just speaks for itself.
Okay, article number 7.
Now, so just to make the point again, in page 46, my lady, on the extreme, the right column, second paragraph. What I made point yesterday, that fracture of either the left or the right superior horn of the thyroid cartilage is the most frequent in right-sided hanging, and then we go on. There's basically saying that there, in this case, if the court concludes that this is a right-sided hanging, then the fracture of the superior horn is the most frequent skeletal injury. And just quickly to read on page 46, my lady, the conclusion. The hyoid bone and thyroid cartilage fractures are not related to the type of hanging, and are more frequent in individuals older than the age of 30. Most frequent injuries are muscle hemorrhages, mechanisms of which are direct pressure and indirect stretching, like I explained yesterday, the tension together with the convulsions. And the location of these injuries is not due to the type of hanging. reference number 8. Lady, this...
Page 48.
Page 48. I think the importance of this is the first word under the summary. It's a prospective study. They decided this is what they're going to look for. They didn't go backwards. They didn't go and look at what was done. They started from here onwards.
So if you look back at records, that's called a retrospective study.
That's correct.
If you set the parameters of your study and you work forwards as things happen, that's a prospective study.
That's right. Yeah. And so this again, these are also recognized authors. R.W. Bayard, he's been to 2 of our conferences as a guest speaker, invited to our pathology conferences as a guest speaker because of his respected, his Australian pathologist. And my lady, under the results, the second paragraph talks about fractures of the neck structures in 47% of cases, and then details the thyroid cartilage 22.5 and hyoid bone 10%. And 6%, 15% had both hyoid bone and the thyroid cartilage. And page 49 of triple L, second paragraph on the right from the bottom. This study shows that fractures of the neck structures occurred in 47.5% of cases with a higher number of thyroid cartilage fractures than the hyoid bone. This contrasts markedly with studies which have shown fractures in less than 15%. Bernard Knight, the gold standard of our literature, says 20 to 40%. And then the last paragraph on page 49 on the right side, variation in the rate of neck structure fractures with age, with older groups generally being more vulnerable to trauma. This was shown in the present study with 67% of older age groups, that is greater than 50 years of age. And the last page is page 50. On the right-hand side, it says, in conclusion, this study has shown that meticulous neck dissection in deaths due to hanging revealed fractures of the hyoid bone and thyroid cartilage in 47.5%. So I think what the gist of all of this is that soft tissue injuries and skeletal structure injuries occur at a high frequency in hanging deaths. And the presence of this injury does not necessarily mean that it was manual strangulation. Lady, and the next reference is on page 57, which shows that you can get a small hemothorax. In this case, I think it was about 50 mils of blood because of resuscitation. We're now into resuscitation-associated injuries.
Is this 57 or 52?
57, I skipped the beginning. I'm just going to the actual content. And page 58, under conventional CPR in adults, a distribution pattern of chest injuries. The average number of fractures observed ranged from 5 to 8. In all studies, the left side of the thorax is more frequently involved than the right. More than 2/3 of the patient have multiple rib fractures, as defined by fractures in 3 or more ribs.
Adjacent ribs.
That's right. And then few lines down, an interesting pattern of injury was revealed in Henriksen's study of of the 212 fractured ribs in 28 patients, rib fractures, 160 of them, pairs were bilateral rib fractures, virtually at the same level.
In other words, left and right side.
Yes, which is what we have here. We have bilateral, virtually at the same level. It's associated with resus. And then the next paragraph, the exact location of sternal fractures rarely reported, but I said that it was the middle third of the sternum. Then the next page 59, paragraph 4.2, extreme on the left column, the second last paragraph from the bottom. Injuries to thoracic skeletal structures are by far the most common complication of cardiopulmonary resuscitation. So when CPR is conducted, chest skeletal injuries are the commonest injuries in resuscitation.
Right, I think we covered that in the abstract.
Yes.
Anything else in this particular article?
No.
Let's move on to the next one, which is number 10, I think.
Yes.
On page 64.
Yes. 64, the introduction. On the right column, paragraph starts with early and effective CPR might be potentially life-saving measures. On the other hand, CPR frequently generates a wide spectrum of iatrogenic injuries to the resuscitated person.
Pause there, please. Iatrogenic means caused by the doctor or the paramedic or the person treating.
Yes.
Okay, carry on, please.
Reported CPR-associated injuries vary from a simple skin abrasion and bruises through to skeletal fractures, to skeletal chest fractures, to severe life-threatening injuries such as cardiac tamponade, that means blood outside of the heart, cardiac rupture, and even liver lacerations. I indicated in my evidence earlier on.
Yes,
yes,
you did indeed. Okay.
Right, and
anything else under that article that you want to draw?
Number 60, page 66. Under the results, the third paragraph, my lady, CPR-associated injuries were found in 93.7% of the cases. Spectrum of identified thoracic injuries comprised rib and sternal fractures, lung injuries, heart contusions, and pericardium. The next paragraph, intrathoracic injuries were identified in 33 cases within the study group. Multiple intrathoracic injuries were observed in 22%. Data regarding ITI in our study group are presented in table 2, and contusion of at least one lung was found in 32% of cases, and 15 persons had contusions of more than 2 lung lobes. And we have 2 lung lobes that are contused here.
Right. Let's deal with the last 2 references, please. Page 69, Bookman and Sokos.
Yes. Yeah, what Michael Sokos and Bookman are saying in the abstract, on the one hand, these measures, that CPR, are essential for survival, but on the other hand, they can damage the patient and thus contain a significant violation risk to both the medical and forensic relevance for the patient and for the physician. And in the bottom of the first page talk about the neck injuries, and you can see there reclining the head for CPR and intubation. And then on the page 70, the first paragraph, almost halfway down, in addition, with the higher age, the risk of underlying osteopenia is increased, especially in females. Injuries must be distinguished forensically from other causes of chest wall trauma, for example, an attack or an accident.
What does osteopenia mean?
Thinning, it's like thinning of the bones.
Right. Now, last reference.
One can go to the first page, that's page 77, my lady, that's the results. And we see there under results, secondary injuries were statistically significant, included skin contusion, abrasions, intercostal muscle contusions, sternal fractures, rib fractures, pericardial contusions, pericardial rupture, hilar and heart contusions, cardiac contusions, and splenic ruptures. And then they go through in the detail their results through the reference here.
Thank you, Dr. Perumal. There's one last question that I want to ask you, and it's of a general nature. We know that Dr. Abrams made no notes at the time, and that she then produced an affidavit a year or so after the death, and it really amounted to a rehash of everything that Dr. Khan had written in his report. So I'm not going to plod through that as well, but there is one aspect that I cannot leave dealt with. In Dr. Abrams's, I suppose you could call it affidavit, and I'll just get the reference number now in a moment. Reference number, pardon me, exhibit number Y. But I'm just going to read you a short passage from it. You don't need to have it in front of you. I'm going to quote from her report, and what she says here is echoed again in various other parts of her report. I just want your general comment. She says the following. It must be noted that there was a 5-day interval between the first autopsy and the second, and the value of the second autopsy is brought into question. And the so-called opinion raised by Dr. Perumal, since he was paid by the alleged accused to perform the autopsy on the wife of the accused and thus not impartial. And she repeats that in various places in her report in one manner or another, and she repeated it in her testimony, as you would have noted.
Yes.
Essentially what she has said is that you are not to be trusted, your opinion has no value because you're a hired gun, and you will just say what is necessary to keep the person who is paying your bill happy. Can you comment on that, please?
Well, lady, again, in line of my responses from the beginning, I say respectfully that Abraham seemed to be living in a rather small world, rather closed and isolated in the sense that she didn't really understand what the role of a second autopsy or an independent autopsy is, what the value of that is. And like I indicated when I did my CV, the role of independent people in terms of forensic pathology services, if one just goes through the Farlam Commission alone and see that the judge has recommended that the further investigation be done by independent pathologists. And I don't know, as I indicated, when I was with Professor Knight, we attended together to a third autopsy. So beyond the second autopsy. So it's a bigger world outside there with the practice of forensic pathology. And I think the other dictum that I mentioned yesterday, called by an individual doesn't mean you called for. I don't think any pathologist that is worth anything will sacrifice their career for a party, whether it be the state or an individual. Because every bit of work that we do, we're fully aware it's a document that will come before the board, is there to be explained or tested. It's not something we write privately that is stashed somewhere. All our documents are written in a form that will come before the court, and it will be tested in terms of the usual process of testing evidence. And to say that an individual is being paid to say something at the level of a professional of standing, I think that's the most ridiculous comment to have made. Because in any way, whether I'm paid by the state, it doesn't necessarily mean that I'm now going to make findings for the state, or if I'm engaged in a private capacity, I'm now going to make findings for that individual. Because in our practice, credibility is the biggest single factor that we need. Because if a witness is found not to be a credible witness, then you might as well just close shop.
It's the major currency.
Major currency for any expert is credibility.
Thank you.
And I won't sacrifice my independence and credibility for any person or institution.
Thank you.
So I find that, to put it in the mildest, an outrageous statement.
Thank you, my lady. As I indicated, without closing my evidence in chief, that is the end of my story. We have discussed this in chambers with Her Ladyship. The plan is to interpose the evidence of Dr. Perumal with the evidence of the specialist psychiatrist, Dr. Panieri Peter, on Monday. After that, my learned friend will request an adjournment until the following Monday, when he will cross-examine Dr. Panieri Peter and then carry on with Dr. Reggie Perumal on the Tuesday or whenever he finishes Dr. Panieri Peter. So, with your leave, may we stand down now until 9:30 on Monday.
That is so. Mr. Panika, you confirm that the trial agreement? Thank you. Dr. Perumal, thank you for your time. You will be called again by Mr. Van der Spey when they are ready to proceed with your cross-examination. We'll carry on Monday, the 11th. Mr. Rohde, you're warned to be here. We will start at 9:30. If you could be a little bit before then. Your bail is extended on the same terms. Thank you.
As the court pleases.